Hi, everybody, and welcome. Today, my special guest is Dr. Jocelyn Wittstein, orthopedic surgeon, and we're going to talk about GLP-1 medications and their implication on your bone health. We're also going to talk about inflammation and the role that can play in your joint and bone health. And we'll also have some questions about what are the surgical considerations if you have osteoporosis or low bone density. And at the very end, we're going to go over some myths versus facts, and you may be really surprised at these answers, so stick around to the end of the interview for that. Hi, I'm LIFTMOR. I'm a physical therapist, a specialist in osteoporosis and bone health exercise, and the founder of Brickhouse Bones. And let me introduce my guest. Dr. Jocelyn Wittstein, MD, is a board-certified orthopedic surgeon and associate professor of orthopedic surgery at Duke University School of Medicine. She specializes in sports medicine and women's musculoskeletal health. Dr. Wittstein's work blends academic research and hands-on patient care. She is the co-author of the Complete Bone and Joint Health Plan, which I read and I loved, and that's why we're talking today. This is a science-based guide that empowers readers to take control of their lifelong bone and joint health through nutrition, exercise, and lifestyle strategies. Dr. Wittstein, thank you for joining me today.
Thanks for inviting me. I've enjoyed seeing you on Instagram and other places.
I know, the wild, wild west of social media and Instagram, right? Well, you've been putting out some amazing content, some really educational content, sharing the research about bone health and joint health. And I'm just really, really grateful for you for doing that. One of the things
I love to educate. That is what I do at work for my patients and my residents and students. And it's an easy thing to translate to social media, surprisingly.
Right. Yeah, well, you do a great job of it. And I know you did a presentation recently about GLP-1 medications, and that it kind of lit a fire in me, and I wanted to have a discussion about that. You know, they're very widely and successfully used right now for different conditions like type 2 diabetes and weight management, some cardiometabolic factors of health. Can you talk about any pros and cons and implications this might have on bone density, especially for people that are concerned about it, that have osteoporosis or osteopenia?
Yeah, these medications have a surprising array of impacts on the musculoskeletal system. In general, having better glycemic control does have, an anti-inflammatory effect, and inflammation impacts our joints and our bones. Just on the inflammation side, even the linings of our joints have receptors for GLP-1, and therefore these medications can also affect inflammation in our joints and may reduce joint pain through anti-inflammatory pathways as well as through weight loss, because, you offload joints, they feel better. As well. So there's probably some biomechanical and biochemical things going on. But for our bones, one of the things we worry about with large amounts of weight loss is the potential loss of lean muscle mass. And we know, especially in menopausal women, that the amount of lean muscle mass we have does correlate with bone density. And, if you're having someone lose a lot of weight through use of these medications, potentially if they're not incorporating strength training at the same time, you can lose a lot of lean muscle mass. The concern would be, does this loss of lean muscle mass lead to sarcopenia? Does it lead to, loss of bone density? And interestingly, there are some mechanisms that these, medications have that may be protective of bone. And there are studies that, look at all these. So there is something called the gut bone axis. So, axis, I should say, not axis, but, our gut produces GLP-1, or in the case of these medications, you're taking a GLP-1 receptor agonist. There are receptors in bone, for this hormone, basically. And the net effect of this medication or GLP-1 on bone is that it upregulates production of something called osteoprotegrin and downregulates production of something called rank ligand. Those are a lot of big words, but the net effect of this whole process is that the cells that break down bone, called osteoclasts, are less activated and live a shorter lifespan, basically. So that there is some shift towards more in favor of bone formation rather than bone breaking down because of that gut bone axis. The other effect of GLP-1 medications is, stimulating the pancreas to, more effectively, have an insulin response in response to glucose. Insulin upregulates osteocalcin, which is a hormone that contributes to the mineralization of bone. And there's something called the pancreas bone loop, basically. So then osteocalcin has a subsequent effect on skeletal muscle to improve glucose utilization, and loops back to the pancreas to also contribute to insulin production. So the pancreas and bone are interacting, the gut and the bone are interacting. There are these loops or axes that exist that you would say, okay, well, here's a reason why these medications should protect bone. And if you look at patients who are using these medications for diabetes, there are meta-analyses showing either a net neutral, like no increased risk of fractures, or in some cases, a reduction in fracture risk and improvement in bone density. If you look at people taking these for obesity and weight loss, when there is not a concerted effort to also include strength training to maintain lean muscle mass, you can see a decline in bone density. But when these medications are paired with strength training, that decline in bone density does not happen. So, if you think of the mechanisms of action, which do lean towards protecting bone, versus the loss of lean muscle mass, which can be associated with loss of bone density, there seems to be like a net neutral effect, or potentially beneficial, unless you're like losing too much lean muscle mass. That's a long answer, but that's kind of all the stuff going on with these medications.
That was a phenomenal answer, actually. I mean, there is a lot happening. So you talked about the overall arching decrease in inflammation through the different pathways of reducing inflammation. You talked about better insulin regulation. So people that are taking it for management of diabetes. Now, diabetes is an increased risk factor for fracture, yes?
Yes.
Yes. So when you have
better controlled,
right. So better controlled diabetes, and you said their studies are showing a decreased or a net neutral or a decreased fracture risk when that's better controlled.
Right. One meta-analysis showed a 30% risk reduction for fracture in diabetic patients utilizing the GLP-1 medications, and others have shown a neutral effect, but certainly not an increase.
Wow, that's pretty powerful. And then the other, when we're talking about weight loss, using the medications for weight loss, if you pair that weight loss with resistance training to protect muscle mass, there's no net loss. Is that what you're saying?
Right. There's not a negative effect on bone density. So the main risk factor seems to be, the kind of significant loss of lean muscle mass.
Is it how much? Is it how much muscle or how much weight loss happens, or how quickly weight loss happens, or does it matter?
Yeah, I mean, a lot of times people are losing this weight quite rapidly, and I think it also could depend on the change in body composition. Like, in many studies, the amount of lean muscle mass people are losing is like commensurate with the total amount of weight loss. It's not like it's like out of proportion. But like the kind of general overarching theme is trying to mitigate the loss of lean muscle mass.
Right. Okay. So really the number one take home message here is these medications can have a powerful impact on reducing joint pain, reducing inflammation. They might even support bone density and how they slow down the osteoclast bone resorption activity. And if you pair this with resistance training, then that can really help protect your bone density along the way and your lean muscle mass.
Right. And before I started, just anecdotally, like reviewing the literature on this in a lot of detail, like in this particular aspect, of the impact of these medications. I mean, I would see patients who are on these medications and they would say to me, like, that a lot of their joints were feeling better. And what would strike me is that it wasn't necessarily just their weight bearing joints. Also their non-weight bearing joints, which are not, don't have the same effect of actual like I mean, of course, your knees, your hips, your ankles, whatever, are going to feel the benefit of weight loss and having less mechanical load on them. But, systemic inflammation does contribute to joint pain. And, people who are obese can have more systemic inflammation, and people who are obese have elevated risk of arthritis also in non-weight bearing joints, right? So it's beyond just the load bearing effect, if that makes sense.
Yeah, absolutely. I've heard that from clients too, and in that all over feeling better, shoulders, wrists, hands, all those things, which I think is just really remarkable. But that's a perfect segue to talk about your book. And my favorite part of your book that I absolutely loved was your discussion on inflammation and managing inflammation. When I was in my 40s, I had chronic pain. I was on prescription anti-inflammatories, and it wasn't until I took these lifestyle changes and behaviors in my nutrition that I resolved it. So I went along for a long time until I took these strategies that you share in your book, and that was the resolution for me. So what led you to really be interested in these strategies for inflammation? Was it even part of your medical school training?
Well, I studied nutritional science as an undergraduate at Cornell. And I actually thought maybe I wanted to be like a dietitian at one point. And I took a lot of nutrition courses. So I received much more nutrition and, diet lifestyle education as an undergraduate student, in that department than I ever did in medical school. So I am so glad that I studied that as an undergraduate, because you don't get actually a lot of nutrition. I mean, you learn about deficiencies, but not just sort of honestly the basics so much of nutrition. And when I thought about doing this book for a really long time, and at first, how things kind of roll around your head and you kind of think about what you're going to do. For the longest time, I just wanted to write like a cookbook that would help people with their bones and joints. And then I started thinking about, I need to explain to people. People don't really understand what is arthritis and what is osteoporosis and what causes it. So it's like, we need to teach people about that. And I'm like, I can't really talk about diet without exercise. And then I started thinking about all the things that patients ask me all the time. And I just decided, okay, this just all needs to be in one place. And then my lifelong friend, Sanina Tskorsky, is a registered dietitian and also a personal trainer, and we were gymnasts together growing up. And so at some point I roped Sydney in, and it was perfect to work with her because I'm an orthopedic surgeon. Obviously I have a lot of the musculoskeletal background and some nutrition background, but having her in her active role as a nutrition and a sports nutritionist, out of college was, working with athletes and things like that was just a really nice compliment. So So I've been thinking about nutrition literally since I was an undergraduate.
Yeah. I can see where that would really enhance your practice and what you share with your patients. Can you talk a little bit about kind of this underlying inflammation that can be such a factor for your patients that are experiencing joint pain, tendonitis, and things like that?
Yeah. So, and it's kind of when I was trying to explain what is inflammation, and it reminded me of one of those writing contests you read about, what is a flame, trying to describe something. And so I tried to use scientific terms, but in a sort of broken down kind of way to make them make sense. But, there's in some cases, inflammation is good. You break a bone and there is a local inflammatory response for the mending, or likewise with muscle, the initial response to training includes transient inflammation, but chronic inflammation is not adaptive. And in your body, this takes the form of these things called cytokines, inflammatory cytokines, which take part in these reactions that, for instance, in your joint, break down, literally, destroy cartilage gradually over time, can, thicken and irritate the linings of your tendons, change the quality of the collagen in your tendons. In your bones, these same inflammatory cytokines can upregulate the the breaking down of bone as opposed to like building of bone. And so like inflammation and these inflammatory cytokines that are literally like little enzymes, part of these chain reactions, are taking us in the wrong direction, or it's sort of, it's common to things like wear and tear arthritis. These same inflammatory markers are part of rheumatoid arthritis, just on a whole other level, a truly autoimmune level of inflammation. After you injure your knee, if you tear your ACL, that knee has mildly elevated inflammatory cytokines, like pretty much for the rest of your life. And those people are more prone to arthritis. So many of these pathways are driven by inflammation. And it's not that diet is going to magically cure everything, but there's plenty of data about all kinds of components of inflammatory diets that do benefit your bones and joints in terms of reducing joint pain, reducing levels of inflammatory cytokines, reducing, the rate at which bone is lost or risk for fracture. The dietary inflammatory index is a basic index of how inflammatory one's diet is. And that is literally associated with your future fracture risk. Things like short chain fatty acids, which are byproducts of dietary fiber, directly impact the processes that lead to bone breakdown or lead to joint inflammation. So our diet really does matter. And I think people don't realize how much it does.
Wow. Okay. You said a couple of big things there.
Sorry, I answer way too long sometimes.
No, I love it. At a cellular level, chronic inflammation can lead to wear and tear and degradation of tissues. And you just said that the dietary inflammatory index is associated with fracture risk. Yeah,
that's been looked at specifically in even in like perimenopausal women. The diet of perimenopausal women, if they have a lower dietary inflammatory index, that is protective against future fractures.
Wow. Well, that's to me is another just super powerful thing to think about nutrition. What would you say in your clients that are struggling with joint pain and inflammation? What are some of the biggest drivers of inflammation that may be the triggers for them?
Well, certainly, like if you have poor glucose control, that's an inflammatory state. Like eating simple processed sugars, diets that are low in fiber, high in saturated fats, like a lot of fried food, red meat. People don't like to hear that, and there's a lot of controversy about red meat, but it does seem to be better to eat leaner proteins. So, lean protein sources that aren't associated with saturated fat. Now, you can find lean cuts of red meat, but and I think it's more about like what is not in your diet sometimes. Like, are you lacking fiber to generate, short chain fatty acids? Are you lacking omega-3 fatty acids? Colorful fruits and vegetables that have, anthocyanins or other, anti-inflammatory phytochemicals. Are you, soy has a lot of anti-inflammatory properties. Some people don't like soy, but, there's a lot of good evidence about anti-inflammatory properties of it. So I think a lot of times it's, kind of like what's not in your diet. Like there are people who don't necessarily have unhealthy diets, just maybe some things aren't in it that could benefit you.
Sure. So some of the things you talked about is not having good control of glucose if someone has diabetes or is insulin resistant, processed foods, greasy fried foods, sugars, simple sugars,
unhealthy fats. Yeah.
Right. But then adding, so some of the top strategies, your favorite strategies for helping to manage or treat this inflammation via food or exercise. What are your favorites? You talked about a little bit. Fiber's one. I love that. Yeah.
I think trying to eat more, and this sounds so basic, like, eating colorful fruits and vegetables. Fruits and vegetables are like there are like many examples, which I explain in the book, where I don't want people to run out and take a whole bunch of supplements, but a lot of the phytochemicals, which are just plant chemicals, they are like the origin of a lot of supplements. Like you'll see like beet extracts. I mean, you could just eat beets. Or
yes.
or you'll see like quercetin supplementation, as an anti-inflammatory, right?
Yeah.
And quercetin is in your coffee, it's in apples, and things like that. But these are all things. And then if you actually delve into the literature, you'll say, oh yeah, there are studies on people with rheumatoid arthritis having less joint pain when they use a quercetin supplement. But where do those things come from? They're all originating from food. A lot of them.
I love it. So
there's studies on fish oil, reducing joint pain. But again, these are so many of these things are actually, food components. So.
Yeah, and you do go over that well in your book. That's like I said, that was my favorite part of the book, is really breaking down these different components that research really supports in reducing inflammation. So if people want more information, there's really, really a great breakdown in your book on that. Soy's gotten a bad rap for a long time, but really there's a lot of data to support its healthful status, even for breast cancer survivors, right?
Right. Modern day data shows, differential activation of, soy has phytoestrogens in it. And, as do some other foods, like it's not just soy, like flax as well and things like that. But phytoestrogens were thought to be a risk for breast cancer at some point. And there are different estrogen receptors. And basically it's, modern day data shows that that phytoestrogens actually seem to be protective, against breast cancer, or at least not a risk for increasing it. And there is data on bone health benefits for soy, related to likely phytoestrogens. So it's certainly not. I think modern day literature doesn't paint it as a risk and more of a benefit.
Yeah, wonderful. I love soy, actually. I use it regularly. I think it's just a really easy and convenient way to get a lot of like micro pack nutrition. So talk a little bit, this chronic inflammation, can that be a contributor to low bone density?
Yeah. Like one of the, some of the mechanisms, I don't want to get too scientific, but there are pathways that are related to inflammation that lead to more osteoclast activity, less osteoblast activity. Nuclear, NFK beta is one. Anyway, there's all these factors that are, functioning at a higher level with more inflammation. So inflammatory states can lead to more risk, and that's probably part of why, having diabetes can be a risk factor. It is an inflammatory state, and I think that there are other lifestyle components that are inflammatory for you, like smoking, is one, but the smoking is bad for your bones for other reasons. It's, it basically can restrict microvasculature. It's the nicotine in it. So smoking is not good for bones. Excessive alcohol intake isn't good for bones. There are some things that maybe we can't control, certain types of medications that you might need that can not be good for your bone health. Like if you're on a chronic antacid, that can, inhibit with calcium absorption, and that can contribute to poor bone health. People who need to be on prednisone chronically, like oftentimes someone who has rheumatoid arthritis, has been on prednisone for years, as well as other disease modifying medications. And, there are certain medications that sometimes we can't avoid that can affect our bone density negatively. It's multifactorial. And of course we have family history can contribute, and sometimes just genetics isn't on our side. So, but diet and exercise are kind of the things I feel like, are most under people's agency, like the thing that they can oftentimes most control. And then of course, whether or not you're able to, or want to use hormone therapy, that's another decision that maybe some people wish they had more options for and don't, but for most people, that's another decision to make, right?
Yeah, yeah, absolutely. Yeah, I mean, I think that's a really wonderful perspective of, even if someone isn't having pain, these nutritional and lifestyle strategies for reducing inflammation can really have long-term downstream benefits for our health, our joints, our bones, all of that.
Mm.
Many of the people in my group ask questions. They're facing a knee replacement or a hip replacement, and they have osteoporosis, and they don't know how their bone density can affect their surgery. As an orthopedic surgeon, how can you help kind of assure them or comfort them or help them get better prepared for this?
Well, yeah, there are several types of surgeries that are affected by bone density. Anything that depends on, fixation of something to bone. Like if we're fixing a fracture and we're putting in a plate and screws, it can be like putting a screw in plaster or putting a screw in the stud that is behind the plaster. How much bite do we say does the screw have? So like sometimes things don't hold as well and bone that isn't as of high of quality. But there are strategies that I think we all take, like when a patient has poor bone density. For example, if I'm fixing a rotator cuff tear and I know someone has low bone density, I'm going to do the repair a little differently. I'm going to make a smaller hole in the bone for the same size anchor so that it can have more grip or, bone to hold on to, as an example. For people who have poor bone density, sometimes our arthroplasty surgeons are more likely to maybe use cement as part of the fixation rather than what we call press fit. For example, just there are strategies, and some of it's intraoperative decision making. Probably people don't want to hear too much about this, but you have to like kind of prepare the bone to put like a stem in, like if you're having hip replacement. And when you put a stem in, it has to have good rotational control inside the upper hip bone. Sometimes there is that control. Sometimes there isn't. Sometimes they're going to add cement to improve the fixation. So we only have what we have to work with, of course. But I think it's always good for your surgeon to be aware, like if you have osteoporosis or osteopenia, because that may affect their surgical, strategies for you. Now, people who have osteoporosis can be more likely to have a fracture after a joint replacement, like after a hip or knee replacement. And it doesn't mean that you shouldn't have a hip or knee replacement, because the whole reason to have a hip or knee replacement is so that you can be more mobile. And I wouldn't want someone to think that just because they have osteoporosis, it might be more likely to have a fracture around their knee or hip replacement if they were to fall. It's of benefit to you to be able to be more mobile, to be able to walk more, to be able to do more weight-bearing activity, because sometimes people are incredibly limited by their joint pain and the restrictions of their arthritis that they can't walk. And we know that walking, the recent meta-analysis, just walking 7,000 steps a day, is, shown to reduce all-cause mortality. So being able to walk and be mobile is so important. So while we may never completely mitigate the risk of potential complications that you might have because you have some osteoporosis, there's a net benefit to you to be able to walk and be mobile in most cases, if that makes sense.
I love that. Yeah. So essentially, you're training as surgeons, you have strategies. So when you can identify any potential issues with the bone, you have strategies to help create a better outcome. And when we're looking at someone whose activity is really restricted, that successful surgery is going to allow them to continue to get back into walking and resistance training and exercise, and to help change their quality of life in the big picture that might not have happened without that surgery.
Right. I mean, I'll give you another example. Like when we do shoulder replacements, there are stemless shoulder replacements. Like we don't put a metal stem down the inside of the proximal humerus bone. But those require really good bone density. So like if you have poor bone density, you're probably not going to get a stemless total shoulder. You're probably going to get a little stem down the inside of your bone because it's going to work better for you. Doesn't mean you can't have a shoulder replacement. It's just you might not get the same exact technical shoulder replacement that someone who has really good bone density is going to get. It's just, things may need to be modified to reduce your risk of problems. But in general, the whole point of having a joint replacement is for you to have more mobility and, more, be able to do more, than you are otherwise unable to do because of pain and restricted mobility.
Yeah, I love it. And I love that you talked about walking. Walking in and of itself isn't necessarily enough to build bone density, but it can help maintain bone density. But more than that, the benefits of walking, like you say, reduce all-cause mortality, right? So to get people on their feet and walking is incredibly powerful.
And walking has been shown to reduce fall and fracture risk, independent of bone density. So, there's a really well done study that I've talked about before that followed menopausal women for 12 years. And this is like 60,000 women, and basically found that the women who walked a total of 4 hours per week, as compared to those who walked less than 1 hour per week, had a 41% less likelihood of having a hip fracture. Now, there are other studies that show that, a walking program didn't increase bone density in women, or there are some studies you can find that show that walking more is associated with higher bone density. But there are many studies that show that regular walking is associated with less fracture risk and less fall risk. So, maintaining mobility and just use as compared to disuse is important. And I know we think a lot about and I like to talk about impact exercises and jumping and how much force we need to generate to create what we call mechanotransduction. But just because something doesn't meet that threshold doesn't mean it's not helping you maintain your bone density. And again, and I've said this before, there's so many real life examples of this. Like being on crutches will reduce your bone density in the limb that you're not putting weight on really rapidly. Also, your muscle will atrophy in weeks, your muscle will be gone. And that's a disuse issue. And even a teenager who tears their ACL or has knee surgery and is on crutches for 6 weeks or so, they're going to have diminished bone density in their leg, in that affected leg, for 1 to 2 years. And that's literally just from not walking on it. So, if you just didn't walk, if you just sat in a chair, or if you were an astronaut and had no gravity acting on your body, you would lose a lot of bone really fast. So weight bearing activity is good for maintenance of bone density, for sure.
I love it. Okay, let's dive into a little bit of myth versus fact. Exercise. So myth or fact, exercise causes wear and tear on joints and speeds up arthritis.
A myth. Do you want me to explain?
If you want to. Otherwise, I think that's great. Yeah, that is a myth. A lot of people will think that, I shouldn't, you can't lift weights because that wears out your joints, or you shouldn't be, riding your bike when you get older because that wears out your joints. But that's not true, right?
Right. And there's even data about running not causing arthritis. Runners are actually less likely to have arthritis, and you could say that's selection, but there's some other studies that are more prospective that kind of take that to another level. But, if you already have arthritis, certain types of impact or pounding on an arthritic joint can exacerbate it and give you some swelling. But in general, no, exercise does not cause arthritis, and our bodies respond. Gradual progressive loading is how we grow muscles and adapt our tendons. And in general, healthy cartilage will compress with load bearing. If a completely healthy person goes and runs for an hour, their cartilage is going to be compressed. But then during the course of the rest of the day, while they're not running around and jumping up and down, it's going to rebound back to its normal thickness. That's part of how cartilage gets nutrition, is it gets compressed and uncompressed. And that's how it's, hydrated, actually.
Yeah. We see that in the spine too.
Yes. Disc. Yeah.
Yeah. Fantastic. To a myth or fact, older adults should never do impact exercise because it's bad for joints and bones.
A myth.
Right. I mean, it should be worked up to appropriately, building an appropriate base of strength. But impact exercise is not necessarily dangerous for people that have done the right preparation, correct?
Yeah, you can't just go from not doing any jumping to all of a sudden doing an 8-inch drop jump. And, some of my favorite sort of building up activities are heel drops, or lighter jumps, a light skipping of rope, which is typically a fairly low jump, to, kind of bigger jumps, or hopping or skipping to squat jumps, things like that. Yeah, there are all kinds of progressions you can do.
Exactly. Okay. Myth or fact, you can't reverse bone loss once it's started?
I need to give a nuanced answer to that. So yes, you can reverse it often partly, but you're not going to restore your bone density to like when you were 30 years old. And the most important thing is that you can stop bone loss. And also what I don't want people to be feeling defeated about is that there is actually, if you are slowing bone loss, you are still winning, because bone loss does tend to gradually decline as we age. So even if you are slowing that decline of bone density, that you are reversing it some. It just doesn't seem like a reversal, because you may not be, not everyone is going to see a gain. There are people who gain bone density through strength training, load-bearing exercise, and impact, and many studies that show how much we can gain, often a few percentage points over an 8-month period, that kind of thing. But depending on how severe your osteoporosis is, how far you are beyond that, like negative 2.5 on a DEXA scan forever, you may not flip yourself from osteoporotic to osteopenic, or you may not flip yourself from osteopenic to normal bone density. But you can typically gain a few percentage points, stop the bone loss, or at the very least slow the bone loss, which again is, believe it or not, you're winning if you're doing that.
Yeah, 100% agree. No loss is a gain, in my opinion.
Yes, for sure.
Okay, collagen, yes or no?
Yes. And
yes,
I can expand on that if you want. So hydrolyzed collagen, there is reasonable evidence that this is helpful for symptoms of arthritis. We don't necessarily have proof that it slows progression of arthritis, but we do see lower levels of circulating breakdown products of collagen in some studies with hydrolyzed collagen. And then I do think there's very reasonable evidence for hydrolyzed collagen that specifically includes type 1 hydrolyzed collagen for maintaining or gaining some bone density. And that is research done on a product called Fortabone, which is a hydrolyzed type 1 collagen. And then for joint pain, there's a different type of collagen called UC2, which is undenatured type 2 collagen. So not broken down, like hydrolyzed is broken into smaller parts. Undenatured would be something that you're not going to ingest because it's not broken down in small enough parts for you to digest. But there's something called this undenatured type 2 collagen. You might see it as UC2 in a 40 milligram capsule. There is reasonable evidence that this can be effective through like an oral tolerance sort of mechanism, in terms of your GI tract recognizing this, and then subsequently in people using this supplement having, again, lower levels of breakdown products of their own type 2 collagen, and some studies that show again pain reduction benefits with this. So I don't think any of these things are a panacea. None of them are going to like reverse your arthritis. And I don't ever want anyone to go run out and buy a million supplements and try taking a whole bunch of things. But I think, reasonable to do a hydrolyzed collagen. And I actually tell people, if you're going to like spend money on that versus glucosamine chondroitin, I'm more in favor of the collagen than the glucosamine chondroitin, because that has, I think, even more mixed evidence. So,
all right. Last one, creatine, yes or no?
Yes. So creatine monohydrate. Now the dose is debated, and there's a lot of studies on, do you need a higher dose than 5 grams per day to have cognitive benefits? Because there do seem to be cognitive benefits to creatine. But for muscle, building lean muscle mass, using 5 grams of creatine monohydrate per day combined with strength training is effective at increasing lean muscle mass. And that can secondarily benefit your bone density. It's not like creatine without exercise is going to just help you build bone density. But we know, again, that like accumulating lean muscle mass and strength training and increasing our strength can help us with our bone density.
Yeah, it was a game changer for me with some of the feeling like I had better quality workouts and also less overall soreness from those workouts. I really appreciate the creatine I use. Thank you so much for all this information. It's been incredibly valuable. Is there anything else you would like to share? And if anybody hasn't followed you yet, Dr. Wittstein on Instagram, you're sharing all this wonderful information. So be sure and give her a follow. Yeah,
I think big picture, we always talk about, yes, we hit our peak bone density, or we kind of top out at age 30. I never want that to be misinterpreted as if you're understanding all this or starting to work on this well beyond the age of 30, which most people are when they figure this out. Like it's not too late to start working on this. We know that a lot of the studies, many of the, you're very familiar with them, Lisa, looking at resistance training are often done on women in their 60s, and people are able to gain strength. They are able to gain bone density. You do need to listen to your body. I never want anybody to be doing something that then takes them out of exercise for weeks at a time, because we do have limitations, and some of us do, and that's real. And some of us have knee pain and joint pain, or had a meniscus removed, or things like that. And I think we always have to kind of respect our body's limitations while figuring out our own personal best plan, and find a way to include strength training, impact if you can, optimize your diet. And then, if you're able to, or you are a candidate for hormone therapy that includes estradiol, that is definitely helpful for your bones. But for people who can't use hormone therapy, diet and exercise are still very powerful tools that are pretty much in your hands to use. So, but yeah, thank you for having me and letting me talk about all this.
Well, thank you. I appreciate that last bit of context very much, as people always think they have to necessarily do it perfectly or they have to do all the things, but we really have a lot of options and variety, especially when considering the intensity. It doesn't always have to be high intensity. We can do moderate intensity, and we can really modify it. We have a lot of tools available to not just address bone density, but reduce fracture risk, which you talked about a lot today.
Yeah, and none of us are like the perfectly screened in and screened out subjects in a research study.
Exactly. So. Wonderful. Thanks so much.
Thank you for having me.